this podcast, we're going to talk about the concept of patient-centered care. What we're talking about really is the fact that we need to know what kind of person has a disease rather than what disease a person has. Before we get going, we need to look at the history of medicine and healthcare and how things have changed over the past 100 years. The traditional role of the patient was to be submissive or passive, and the doctor or therapist took on the role of the parent. So it was very patriarchal. The patient was seen to be submissive, and there's been a gradual shift towards a more mutual approach and more of a partnership. There are of course issues with this, and we do get the situation now where patients feel that they can demand treatment that probably they shouldn't be receiving. A good example would be certain plastic surgery procedures. Tied closely to this is our perception of ourselves about what we can and can't offer to our clients or patients, what the scope of our practice is, and what our limitations are. One of the things about being a professional is knowing what we can't do, and there's no shame in saying this is not within my scope of practice. One of the problems is that very quickly when you graduate you will become an expert in your chosen field, and by definition you will have more knowledge than most of your patients. I just had to share this with you. Many years ago, when I was a junior grade physiotherapist, I was working with another physiotherapist who referred to himself as an expert, and the patient that he'd been speaking to came up to me later on and said, "You know what an expert is, don't you, Stuart?" And I said, "No." And he said, "An X is an unknown quantity and a spurt is a drip under pressure." So try and remember that. Obviously you will be experts, but sometimes the patients are experts in their own condition as well. If we look at the past 100 years, very much the doctor was in charge initially. I've now replaced this with physio because that's what we're into. Going back to about 1975 or something like that, I think the doctor always made the decisions and told the physios what to do. Then we were given the status of being able to make our own diagnoses and problem solve and clinically reason what we were doing. And then the patient was seen as being a more active participant in that process. The patients very much became partners, and we now have a thing called the Expert Patient Program, where patients are deemed to be experts in their own condition. One of the things that you'll come across a lot is the term paradigm. A paradigm is just a way that we look at the world, and in medicine there are broadly two paradigms. There's the medical model and the biopsychosocial model. The medical model sees the patient as a collection of syndromes or symptoms or problems or numbers, and the biopsychosocial model sees the patient as much more of a partner in a condition. I think it's important to be pragmatic. There are occasions where the patient isn't an expert and we have to do things for the best interest of the patient. So I've just illustrated two extremes here. You've got a newborn baby who needs nasopharyngeal suction to save its life. You can't ask the baby what it wants, you have to do the treatment. Compare that with a person with chronic low back pain who's had the back pain for 15-20 years, who has a great knowledge of the symptoms and the symptom behaviour and can problem solve to a high degree. When we treat patients, we should always be cognizant of the experiences of that person, and they will always be unique to that person. So you can have two people with the same diagnosis but with very different experiences, different ideas about what's wrong with them, different feelings and perceptions about their illness or disease, different views about how this is going to impact their lives, and probably most importantly, different expectations of what should be done. All of these require unpicking very carefully. There is a lot of evidence in education and healthcare that if we can include our students or our patients in decision-making processes, the outcome is more successful. And I've got a reference here from 2003. And again, another quote: "The process of healing depends on knowing the patient as a person in addition to accurately diagnosing their disease." I'm not suggesting that this is easy in a busy environment. You will sometimes get this wrong, and you will refer to people as the hip replacement in Bay 3 or the back pain in Bay 5. I've done that myself, but try and think of them as a whole person. This is not just an academic exercise. The reason that we should do this is that it makes us better therapists. If we can understand what it's like to have a condition or a disease, we're far more likely to be empathetic and far more likely to be effective with the treatments that we give to our clients. The evidence suggests that if the patient is happier, they're more likely to comply with any treatment that we suggest. They're more likely to take medication, do their exercises, turn up for appointments, and that's what we want. And probably more importantly as well, decrease complaints and litigation at a later date. I've just listed 6 parameters that are thought to be key in patient-centered care. One of them is to explore the disease and the experiences of the person with that disease. Number 2 is to understand the whole person. Number 3 is to try and find some common ground regarding how you're going to manage this person's condition. Most of the clients that you see will have chronic illness. Number 4 is incorporating prevention and health promotion if possible. Number 5 is enhancing the relationship generally. And number 6 is being realistic. There's no benefit in being, disingenuous to your patients. You have to be truthful to them. One of the areas that physiotherapists have expanded into more recently is the area of prevention of illness and disease and health promotion, and that involves getting to know the patient very well and respecting their opinions and their thought processes. As with most situations in life, it's important that you find a common ground. Very often our patients are as busy as we are. They have families, they have other commitments, they have work, they have other pressures. We need to try and meet them in the middle. It's important to recognize that different patients respond differently and have different needs. Some patients will need more praise than others, some will need more support than others, and some patients will want you to ask them questions and some will not. Some patients will not want to disclose things to you, and that can be quite difficult if you're trying to form a relationship with your patients. Because we're dealing with a human situation, there is no one-size-fits-all recipe to this. So to some degree you'll have to find your own way to get the best out of your clients. I think that's easier than you might expect. Once you start to work in an area, you do start to learn tricks of the trade very quickly. Learning to listen is important. I think we're all so busy that we very often don't listen to each other. We're just waiting for our next turn to speak. And we need to look at the patient as a whole. There are some real issues here though. There's sometimes a conflict between what we think we should be doing for the patient and what the patient actually wants. Patients might have unrealistic expectations. There is a risk that we may inadvertently invade somebody's privacy if we appear to be asking questions that are not strictly relevant to the pathologies. Sometimes it's not necessary, so there are occasions where you have to do something to the patient. So we showed the example before of the young baby having nasopharyngeal suction, and also it's time consuming. It takes a long time to get to know somebody, and very often we don't have that amount of time. Another one of the issues that you're going to encounter now is the Googler, the patient or the relative that comes in and has done their homework and they've been on Wikipedia and they know everything that there is about this condition, and they will challenge you about things. That's one of the reasons why it's important that we teach you research methods, so that you can challenge politely the data that patients might give to you that's inaccurate or poorly executed. Also, we need to think about where we're doing our consultations with the clients that we have. Sometimes we don't have a choice in this. Sometimes we're seeing patients in a very noisy, chaotic environment. But just to give it some thought, if you can think about where you're going to see your patient to get the best information from them, sometimes a little forethought will make all the difference. I think we live in a world where the saying the customer is always right is now accepted, and some patients will see themselves as customers, and not very often, but they will occasionally demand treatment and they will get angry with you. So don't take it personally. It will happen. If you're seeing hundreds of patients in a year, it's going to happen. Try to remain calm, engage them in conversation, Be empathetic, and above all, avoid an argument and set professional boundaries with them as well. The world is much smaller now. We live in a multicultural society, which is wonderful, but occasionally you will have problems with communication with people who don't understand English. If you can, try and ensure that there's an interpreter present or a family member, and think carefully about whether the client or patient actually understands what you're asking them to do. Also, you need to be sensitive towards religious and gender issues as well. One of the things that I used to find a problem wasn't the patient themselves, it was the relative or the parent or the son or the daughter. This can be very difficult to handle. Try and remember that the patient is your responsibility, and unless the patient doesn't have capacity, you should direct your questions and your gaze towards the patient and try and get them to engage with you. The exception to this, of course, is if the patient says, "Look, I don't understand you, I can't hear you, can you please speak to my son or my daughter?" Kind of debated whether I should include this slide or not, but I've left it in. You will get days that are bad. I think this slide speaks for itself. Sometimes no matter what you do, you can't win. Try not to take it too personally. I think we're much better at including the patient in decision making now. So a fairly recent study showed that 87% of patients said that the GP was good at listening to them, and 76% of inpatients in hospitals said that they had things explained to them, and that's extremely important. I think one of the problems at the moment is we don't really know how to measure patient-centered care. We can measure components of patient satisfaction, such like, but there isn't a universally accepted measure of patient-centered care. It's very easy to forget that, especially with chronic disease, the patient will have had a lot of experience of that disease. They will probably know the symptoms much better than you do, so try and bear that in mind. Just going to end with a couple of hypothetical examples. One's hypothetical and one's not. So this is the hypothetical. Wayne is a footballer who wants a sports massage, and he says that you're not doing it hard enough like the last person who did it to him, and he wants you to hurt him, and he's paying you £500 an hour. What do you do? So this is one of the problems. If a patient demands things that are unreasonable or not indicated, you have to stand by your professional judgment and say to this person, "No, I don't see the logic in hurting you. There is no medical evidence to suggest that this is the right thing to do. If you don't want me to treat you, I won't, but this is the treatment that I propose to do." The final slide here is a rather extreme example, but a real life example. Michael Jackson, as you know, passed away a few years ago of propofol intoxication. Propofol is a very strong sedative that's used to anesthetize people prior to major surgery, and that was the only way that he could get to sleep towards the end of his life. He employed a cardiologist, Conrad Murray, and he paid him $150,000 per month. That's a huge amount of money, and just imagine the pressure that somebody is under to do whatever the patient wants. So I'm not suggesting that you will be paid £150,000 a month, but just for a moment put yourself in the position of this doctor who's being paid huge amounts of money to do whatever the patient requests, and what would you do? So I hope you found this presentation useful, and if you have any queries, please let me know.